I'm very happy and glad to give a short and crisp introduction of our today's speaker, Dr. Rafeeque sir. Dr. Rafeeque sir, because he has been very renowned at and he is taking care. He's been MBBS and MD in medicine, and he is a senior consultant physician and cardiologist, and he is a director of Pearls Hospital, Nanded. And he has a tremendous experience of more than 25 years now, and out of which he has 10 years of experience in ICU and handling a critical patient. And when it comes to the academics, it is a very strong point of the sir has been participating in various national as well as international conferences. Like if you see about the national conferences, sir has been the part of EPICON, then MAPICON, CAD, and SIPS. And when it comes to the international conferences, sir has participated in APS 2013 in Japan and ADA 2014 in Australia. Sir has attended, across the globe, sir has attended the international conferences, and when it comes to the ESC conference, so sir has attended it in 2018 in the Germany, and sir has also presented 4 papers in the international journals. And when it comes to the patient awareness and feeding for his patients, sir has a very strong social media handles, like he has more than 4,600 followers on his YouTube channel and having more than 170 videos for his patients, and that is very patient centric. And if someone has not subscribed it, so I must recommend that he should go and check out this video. They will find out in every topic that patient should know for his benefit. And when it comes to Facebook also, there are around 6,000 followers sir is having. So after having a busy schedule as well, sir is taking out his time to make a quality content for his patient, because most of the time patient does not in the condition to listen the patient or doctor in the cabin. So he can take out his time at home and he can see the educational videos of the sir. So that is a very strong thing, that very, very rare of the doctor is having this much of engagement in social media after having a so busy schedule. So heads off to you for this, sir.
Thank
And
you.
now, sir, currently sir is at Pulse Hospital, and he's a director here, and he's working as a senior consulting physician and cardiologist. So with this short introduction, I would like to hand over the session to Dr. Rafeeque sir. He will take us through Azelnidipine, a new CCV, and over to you, sir.
Thank you very much, Shahzad, for nice elaborative introduction of me. I welcome all the delegates on this meeting, and few of them must be watching me on this program is being telecasted on YouTube also live. So many my subscribers are following on YouTube also this event. So friends, the topic given for today's webinar is about Azelnidipine molecule, which is a powerful, promising game changer of the present and the future in hypertension. So this is the title of today's webinar. We will cover this webinar under these following headings. We will see why hypertension is called a silent killer, what are the actual BP goals and guidelines, how the elevation of blood pressure and aldosterone leads to end organ damage, and what are the new calcium channel blockers which are beyond the conventional CCBs, especially focusing azelnidipine, how it is having multifactorial action on heart, kidney, adrenal and nervous system. We will briefly review certain clinical studies pertaining to azelnidipine and blood pressure, aldosterone, heart rate, pedal edema, benefits and all. Similarly, its role in diabetic patients also. And we are going to see advantages of azelnidipine in comparison with amlodipine and other CCBs. Finally, we will see advantage of azelnidipine in our Indian context, and we will summarize this meeting. So, this is my hospital, Pulse Hospital in Nanded, from where I am delivering this talk. My dear friends, hypertension is a major cause of premature death worldwide. We know this. And around 1.28 billion adults between 30 to 79 years worldwide, they have hypertension. And out of that, 46% of adults with this problem, they are unaware. This is the sad part of this disease. Almost 50% of the patient, in spite of having the disease, they don't know that they have this problem because of the silent nature of the disease. Because most of the time it doesn't produces any signs and symptoms. This is the reason it is called silent killer. And it has been linked with the many disorders like heart attack, stroke, dementia, kidney failure and vision loss if not treated timely. So hypertension, that's why it is called as silent killer. In our country, you can see cardiovascular disease, they are the most prominent important causes of death and disability, and mortality has gone by 31% in last 25 years. And better hypertension control can prevent between 400 to 5 lakh premature deaths in India. And this problem led to 1.6 million deaths, more than per year what the COVID has caused the deaths, and most important cause of disease burden in India. So this hypertension is the most important risk factor for CVD in India. If you see the disease burden when hypertension is uncontrolled versus those patients who have controlled hypertension, the patient in whom the blood pressure is uncontrolled, they have the risk of end stage renal disease up to the tune of 95%, heart failure 88%, stroke 57%, coronary heart disease 44%, all cause mortality 30%, and peripheral artery disease 23%. So this is the huge amount of burden or the risk those patients who have uncontrolled hypertension they have. Then if you see the main factors that contribute to the development of this problem and its complications, so the social determinants and drivers are globalization, urbanization, aging, income, education and housing. Ultimately, they result into behavioral risk factors like unhealthy diet, tobacco use, physical inactivity and harmful use of alcohol, leading to certain metabolic risk factors like high blood pressure, obesity, diabetes and raised blood lipids. Finally, terminating into some target organ damage in the form of cardiovascular diseases, kidney disease, heart attack, strokes and heart failure. So if you talk about end organ damage in this problem, so they can be divided into 4 groups: vasculopathy, cerebrovascular damage, heart disease, nephropathy. Vasculopathy includes endothelial dysfunction, generalized atherosclerosis, aortic aneurysm, remodeling and arteriosclerotic stenosis. Whereas cerebrovascular spectrally includes acute hypertensive encephalopathy, intracerebral hemorrhage, lacunar infarction, vascular dementia and retinopathy. When it comes to heart diseases caused by uncontrolled hypertension, they include left ventricular hypertrophy, atrial fibrillation, coronary microangiopathy, CHD, myocardial infarction and heart failure. In the kidney group, it can cause albuminuria, proteinuria, chronic renal failure and mild acute chronic renal insufficiency also. If you see the overall cardiovascular risks associated with this problem, so you can see this is very wonderful slide. As on the x-axis and on the y-axis, on the one axis the risk factors are shown, and on another axis the grade of hypertension is shown. As the number of risk factors they increase and as the grade of hypertension increase, the risk of developing cardiovascular event increases significantly. You can see those individuals who have normal blood pressure with no risk factor, they still have average risk of developing the cardiac events. 10% of probability of cardiovascular event within 10 years and 0% risk of cardiovascular death per 10 years. Slight risk 10 to 15% probability of a cardiovascular event within 10 years and less than 4% risk of cardiovascular death per 10 years. Moderate risk 5 to 20% and 4 to 5%. Significant risk 20 to 30%, 5 to 8% risk of death. Significant risk means more than 30% probability of developing cardiovascular event within 10 years and more than 8% risk of developing cardiovascular death per 10 years. So you can see as the number of risk factors increase and as the grade of hypertension increase, there is also increase in the risk. Suppose an individual has more than 3 risk factors and he has grade 3 hypertension, he will have very significantly elevated risk, means more than 30% risk of developing cardiovascular event within 10 years and more than 8% risk of developing death per year. On the contrary, suppose an individual has absolutely normal blood pressure with no risk factors, WHO and Chinese. Amongst all these, you can see 130/80 is most of the societies what they have recommended as a normal cutoff, or most of the societies they have given class 1 level of recommendation and level A evidence, level of evidence A. Except 2021 WHO, they have recommended 140/90 in all hypertensive patients without comorbidities, and 2022 Chinese guidelines, they also recommended less than 140 in patients, older patients more than 80 years old. Rest of all the societies they have recommended 130/80 as a cutoff target for blood pressure control. Now, what are the goals of management of hypertension? The aim or the goal is to decrease the blood pressure to less than 140/90 in patients with hypertension plus diabetes or the renal disease. BP goal should be less than 130/80, and another aspect is to reduce the CVD complications, cardiovascular, renal morbidity, mortality. This should also be our aim. Means optimal management of hypertension includes both pharmacological interventions as well as non-pharmacological interventions like lifestyle. Similarly, implementing early preventive measures means minimizing complications associated with hypertension. If you see the challenge of uncontrolled hypertension in our society, it is very big. Almost 40 to 50% patients of those hypertensives, they have uncontrolled hypertension. Means 50% means half of those patients with hypertension established diagnosis, they don't have their blood pressure under well control. So this uncontrolled hypertension can be a pseudo-resistant hypertension, it can be a resistant hypertension, or it can be secondary hypertension also. Pseudo-resistant hypertension can further be divided into white coat effect, inaccurate BP measurement, medication non-adherence, or under treatment. Resistant hypertension is very rare, only 2 to 5% of the cases you get this, and secondary hypertension also is not common. Example includes pheochromocytoma, renal artery stenosis, and certain endocrine disorders like Cushing syndrome, hypohyperthyroidism. So these are the causes of secondary hypertension. They are only 3 to 5% amongst all the total hypertension spectrum. There is one entity called difficult to control hypertension. It is seen in older age diabetic and CKD obesity patients, and they represents a very mixed group of patients with target organ damage and CV or renal disease. Now, if you see the treatment strategy, core drug treatment strategy for uncomplicated hypertension, so the initial recommendation is combination of either ACB, ARB, CCB, and diuretic. You can select any two drugs among these three. Nowadays, AC inhibitors we rarely use, so we will consider only ARB whenever it comes to AC or ARB. ARB should be considered practically. Then CCB, diuretics. When you want to combine, you can either combine ARB with CCB or diuretic. Second option or step 2 is you can combine all the three, ARB, CCB as well as diuretic. And blood pressure, if it is uncontrolled with this combination, it can be labeled as a resistant hypertension. Then you need to add spironolactone in the dose of 25 to 50 milligrams. Or even you can add alpha blocker or beta blockers also. For beta blockers, certain indications are there which I will be telling later. Same thing shown differently in this slide. First, you begin with either ARB single drug. If you want to combine, the blood pressure is more than 149, you can combine ARB with CCB or diuretic. If the blood pressure is uncontrolled, then you can combine all these three, ARB plus calcium channel blocker, diuretic also. Even if the blood pressure is uncontrolled, you can confirm the confirm the diagnosis of resistant hypertension, and you have to exclude pseudo-resistant hypertension and secondary causes for hypertension. Simultaneously, also you have to reinforce patient for lifestyle modifications like salt restriction, moderation of alcohol consumption, dietary improvements, weight reduction, regular aerobic exercises, smoking cessation, and C for the sleep apnea if appropriate. Even if the blood pressure is uncontrolled with three drugs, then you can add spironolactone or other diuretic, alpha blocker or beta blocker. Beta blockers, they are recommended only in compelling indications. There are certain indications for beta blockers like heart failure, chronic coronary syndrome, atrial fibrillation, and sometimes in women when they are pregnant or about to conceive pregnancy. If you see the recommendations by the various societies for these combinations, almost all the societies, ACC, AHA, ISS, WHO, Chinese even, they have recommended these three class of drugs in combination. Almost level of class of recommendation 1, level of evidence A. Only International Society of Hypertension, they have suggested to begin with angiotensin receptor blocker plus calcium channel blocker in a low dose. Then if the blood pressure is uncontrolled, the dose can be increased. Even if the blood pressure is then uncontrolled, then you can add diuretic to it. Then finally you can add spironolactone. Rest of the things more or less common. You have to select from these three drug classes. When you want to talk about a selection of antihypertensive drug in certain special population, for those patients who have coronary artery disease, angina in particular, so recommended drug is beta blocker and calcium channel blocker. Class of recommendation 1, level of evidence C. Those patients with prior myocardial infarction, beta blocker or AC inhibitor, ARB. Class of recommendation 1, level of evidence O. C. Those patients who have heart failure, they have the option of HFrEF, means heart failure with reduced ejection fraction or heart failure with present ejection fraction. ARB, angiotensin receptor neprilysin inhibitor, ARNI is recommended. Class of recommendation 2, level of evidence B. Prior stroke, AC inhibitor, diuretic, or combination of both. TIA, calcium channel blocker or ARB. You can see beta blocker is not recommended as first line choice in neurological problems. So only in cardiac problems you can prefer beta blockers. In diabetics, you have the option of angiotensin receptor blockers and SGLT2 inhibitors and also GLP-1 RAS agonists. SGLT2 inhibitors and GLP agonists, they are basically anti-diabetic drugs. still they have been used in cardiac failure problem, and they have been also recommended for the management of hypertension also as antihypertensive drug also. CKD patients with microalbuminuria, renin-angiotensin system inhibitors, and those without microalbuminuria, same renin-angiotensin system inhibitors. If you see the two classes of antihypertensive drugs acting synergistically, they could help to significantly improve the outcome. Like the same thing, if the blood pressure is uncontrolled with single drug, you can add another with CCB. If it is uncontrolled, go on adding telmisartan or ARB, go on adding diuretic, like that. Now coming down to molecular mechanism of calcium channel blocker. So we will not go into the detail of this slide. There are three types of calcium channels available on the cell membrane: voltage gated calcium channel, receptor operated calcium channel, stretch operated calcium channel. Our main importance, our main focus is on voltage gated calcium channel. They can further be divided into L type, T type, N type, P type, and R type. So this L type, the main targets of our calcium channel blockers is L type. They are present in cardiac myocytes, smooth muscle cells of the vessels, and endocrinal cells. T type of receptors or calcium channels, they are present in neurons, endocrinal cells, conduction system of our heart, pacemaker, atrial cells, and Purkinje cells. Purkinje fiber cells, they have T type of channels, and NPR type of channels, they are present in neurons like neurons of the brain and pituitary gland. If you see the problem with the conventional calcium channel blocker, so they had the problem of reflex tachycardia, and there was much incidence of pedal edema with their use, and they don't have any role to play in elevated proteinuria level. So we need to look beyond the conventional CCBs to tackle these three issues for carrying our heart and kidneys. So for controlling the gateway of cardiorenal disease with azelnidipine, a newer molecule which acts on both elevated aldosterone level as well as elevated blood pressure level, acts on our heart and acts on our kidney also. So this azelnidipine, which is a novel CCB, here you can see three type of channels, graphic representation, L, N, and T type. This nifedipine mainly blocking the L type, amlodipine also L type, and this nifedipine and amlodipine L type, cilindipine blocking the N type, and this our azelnidipine and eflodipine. They both block L as well as T type of receptors, which is clearly seen in this diagram. When we talk now, our focus will be azelnidipine. You can see here it is a new dihydropyridine calcium channel antagonist, and as I said, it is a L and T type of calcium channel blocker, composed of a racemic mixture of containing a 1:1 ratio of active R enantiomer and the inactive S enantiomer. Now, what are the effects of blocking these channels on the various organs? So, if you block L-type receptors, they on the heart, they will cause decrease in the contractility. On the sympathetic nervous system, they will increase the pulse rate. On the kidneys, they will have increasing the glomerular pressure effect. When it comes to N-type, blocking the N-type channels will reduce the heart rate, will decrease the pulse rate, will decrease the glomerular pressure. Same things will happen with the T-type blockage. So our azelnidipine blocks N and T-type, both these receptors, thereby producing reduction in the heart rate, reduction in the blood pressure, and reduction in the proteinuria. Also, in addition, has reduction in the aldosterone secretion. So this is the unique or enhanced effect with azelnidipine you get, which other CCBs they don't have much. Here you can see multifactorial action of azelnidipine blocking L type and T type calcium channels in the heart, resulting into reduction in the heart rate and resulting into the vasodilatation. It has 17-fold higher lipophilicity than of amlodipine, so definitely this drug should be preferred. Also, this molecule blocks the T-type receptors present in the afferent arteriole, thereby reducing the intraglobullar pressure, reducing the proteinuria. Also, this drug azelnidipine blocks the T-type of calcium cells which are present in the zona glomerulosa of the adrenal gland, inhibiting strongly aldosterone synthesis and release, thereby avoiding all the toxic effects of the aldosterone on the body. One more beautiful effect this molecule has, which has a negative effect on the SA node, inhibiting the T-type calcium channel activation leads to prolongation of the late phase for depolarization, causing the reduction in the heart rate. So these were the actions of the azelnidipine as far as various organs are concerned, and I have said various other unique effects of azelnidipine also. Now there are certain studies which are present in the literature regarding azelnidipine. We will review certain studies. We will only focus on their main features. So first study is the study in which azelnidipine is compared with amlodipine, and their effect is observed on the chronic morning hypertension and home pulse rate control. Here you can see those patients who have received azelnidipine. There you can see significant reduction in the systolic as well as diastolic blood pressure, and also a significant reduction in heart rate. Heart rate was greatly reduced in those patients who have more than basic basal pulse rate of more than 70. In them, 8.2 minus heart rate reduction was noted as against only 3.8 with amlodipine. So these findings suggest that azelnidipine may be useful antihypertensive agent for patients with morning hypertension. Second study, it has shown the effect of azelnidipine on the carotid arterial hypertrophy, which is a strong independent risk factor for the cardiovascular morbidity and mortality. Here you can see a 6-month therapy azelnidipine effect on the carotid wall thickness in the form of, there are two markers of assessing carotid arterial thickness. One is pulse wave velocity, another is intima media thickness. So you can see greater reduction in both. Both are arteriosclerotic markers, pulse wave velocity as well as bilateral intima media thickness. Both were significantly reduced after a 6 months azelnidipine administration. So this is how it has shown its effect. Similarly, there was one study by the name of aorta was conducted, in which azelnidipine was combined with olmesartan in one group, and this olmesartan was combined with amlodipine in another group, and their effects were studied after 12 weeks. So total number of patients were 50. For the first 12 weeks, all patients they received olmesartan in 20 mg per day dose. Hypertensive patient, BP more than 140/90. Then the patients were randomly assigned either to azelnidipine 16 mg OD or amlodipine 5 mg OD. 25 patients in each group. They were studied further for 24 weeks. Their central blood pressure and left ventricular mass index, they were measured after the at the end of the study. So these were the findings. You can see olmesartan azelnidipine had greater effects on central blood pressure and LV mass index than did olmesartan and amlodipine. So these differential effects on central blood pressure and left ventricular mass index may have important implications definitely for cardiovascular risk reduction. So this was very important study by the name of aorta study. It was published in Vascular Health and Risk Management 2011. This study actually it is a compilation of various around 14-15 studies. It was a Chinese study in which around 14 studies were combined. Approximately 600 patients were enrolled. All they have mild to moderate hypertension. All the patients they received azelnidipine in the dose of 8 to 16 mg for a period of 8 weeks to 12 weeks. All have noted significant reduction in blood pressure. In these Chinese patients, it has been seen with mild to moderate hypertension. In addition to antihypertensive effect, azelnidipine had other protective effects as well on the heart, like antioxidative action, decreasing heart rate and improving systolic diastolic function. And this molecule was very well tolerated in all the Chinese patients, and there were no severe adverse events except 1 or 2% of the patients they had headache, flush, edema and palpitation. Only 1 to 2% patients. So its efficacy was confirmed in this study. How much safe it is you can assess now. In this study, they have studied the antiarrhythmic effect and the improvement in the cardiac sympathetic function with this drug azelnidipine. You can see total number of ventricular extrasystoles after switching to azelnidipine compared to that of amlodipine were drastically reduced. Similarly, washout rate of 1231 MIBG scintigraphy before and after switching to azelnidipine was decreased. What this shows? This shows ECG decreased significantly after switching to azelnidipine compared to that during amlodipine treatment, and the washout rate decreased significantly from 23.4 during amlodipine treatment to 18.4 after the switch to azelnidipine, suggesting that cardiac sympathetic function was also improved in the azelnidipine group. Similarly, the free radical 8 isoprotein was significantly decreased, while antioxidant adiponectin levels were significantly increased after the initial treatment with this drug. After switching from amlodipine, azelnidipine significantly decreased heart rate and the total number of extrasystoles also. NORAD level and the low frequency to high frequency ratio, which is a marker of autonomic influence over the heart, sympathetic ratio we call it, significantly gone down, and the washout rate was significantly reduced to 1231 on 1231 MIBG by significant scintigraphy. Finally, azelnidipine inhibits the enhancement of sympathetic nerve activity and the progression of arteriosclerosis through its antioxidative effects. Now, in this study, effect of calcium channel blockers on glucose tolerance, inflammatory state, and circulating progenitor cells in non-diabetic patients with essential hypertension was studied as compared to amlodipine. So this drug, azelnidipine, when compared with amlodipine, the heart rate after azelnidipine administration was significantly lower. 120-minute glucose levels were also significantly lower. CRP level, interleukin 6 level, circulating number of hematopoietic progenitor cells after azelnidipine administration is significantly higher. So results suggest that azelnidipine treatment may have beneficial effect on glucose tolerance in diabetic patient insulin sensitivity, inflammatory state, and number of circulating progenitor cells in non-diabetic patients with essential hypertension. Again, confirming its usefulness in metabolic syndrome and obese diabetic or pre-diabetic patients. In this study, famous by the name of BOAT-2 study, balloon versus atherotomy trial 2, full name of this study. In this, maximum carotid intima media thickness were reduced in azelnidipine group but not in amlodipine group. Here you can see azelnidipine group representing decreased reduction in the intima media thickness, whereas there was no effect with amlodipine group. Similarly, the inflammatory markers like tumor necrosis factor alpha, monocyte, chemoattractant proteins were significantly reduced in azelnidipine group. So azelnidipine delayed the progression of carotid atherosclerosis, which was not observed with amlodipine, and this action was mainly due to reduction of the inflammatory markers like monocyte, chemoattractant proteins, and tumor necrosis factor alpha. So this quality is shared by only azelnidipine, not by amlodipine. In this study, they have shown how azelnidipine can cause reduction in the aldosterone and cortisol. We can see aldosterone secretion from the H29 5R cells was suppressed in a dose-dependent manner by all calcium channel blockers, and the effect of azelnidipine and eflornithine on the secretion from these cells were more potent than that of nifedipine. Where you can see release of cortisol was much lower as compared to amlodipine and nifedipine. Slightly better reduction with eflornithine. Azelnidipine, so therefore, my friends, is a promising antihypertensive drug for the treatment of aldosterone involved in cardiovascular and renal diseases. So this calcium channel blocker, they have all the calcium CCBs. They have the same antihypertensive action. They have a vast difference in their pharmacological action, their pharmacokinetic profile, and their adverse actions. Amlodipine is safe, gold standard, effective drug of choice in chronic hypertension due to its slow and prolonged duration of action, low cost, and lesser incidence of reflex tachycardia. But it has a big issue of pedal edema. So and also the blood pressure lowering effect of amlodipine and other new drugs is not vast, means the difference is not that significant between other newer CCBs and amlodipine, BP reducing effect. So the novel CCBs differ in their lipophilicity, vascular selectivity, pharmacodynamic properties, anti-systemic action, anti-atherosclerotic action, renoprotective action, neuroprotective actions. The incidence of baroreceptor activation and pedal edema was also found to be lower in the newer calcium channel blockers. Hence, the new generation calcium channel blocker could be preferred for various cardiovascular problems. In this study, they have shown how azelnidipine has and lesser incidence of reflex tachycardia, but it has a big issue of pedal edema. So and also the blood pressure lowering effect of amlodipine and other new drugs is not vast, means the difference is not that significant between other newer CCBs and amlodipine, BP reducing effect. So the novel CCBs differ in their lipophilicity, vascular selectivity, pharmacodynamic properties, anti-systemic action, anti-atherosclerotic action, renoprotective action, neuroprotective actions. The incidence of baroreceptor activation and pedal edema was also found to be lower in the newer calcium channel blockers. Hence, the new generation calcium channel blocker could be preferred for various cardiovascular problems. In this study, they have shown how azelnidipine has protected the myocardium in hyperglycemia-induced cardiac damage. The treatment with the azelnidipine significantly reduced the level of troponin I, CK-NAC, LDH, CPK-MB, uric acid, alkaline phosphatase. Also, reduction in the various inflammatory markers like tumor necrosis factor alpha, elevation in the level of interleukin 4 were observed. A significant decrease in the serum cholesterol, triglyceride, and significant rise in the level of good cholesterol HDL was also observed, meaning a better positive effect on the lipid profile was seen. Azelnidipine corrected the disordered or distorted antioxidant enzyme profile, resulting in a significant decrease in the level of lipid peroxides, nitric oxide, and carbonated proteins. So this azelnidipine treatment can reduce the risk of hyperglycemia, induce metabolic disorders, and its role can be further extended to explore its therapeutic potential in diabetic patients with cardiac complications. When it comes to comparing with the 4th generation CCB, because azelnidipine is a 3rd generation CCB, when you compare it with cilnidipine, so both cilnidipine and azelnidipine, they provided at par comparable BP and heart rate lowering effects. As such, there was no difference. But in those patients who have heart failure with preserved ejection fraction, when they are shifted from cilnidipine to azelnidipine, they tended to have low levels of brain natriuretic peptide and could reduce and they can reduce in that group. It has been shown that neurological dysfunction in the cardiac sympathetic nerve activity was less. So azelnidipine could reduce in a better manner, say, dysfunction in the cardiac sympathetic nerve activity and the level of brain natriuretic peptide in those patients of heart failure who have preserved ejection fraction. Azelnidipine proved to be better molecule than cilnidipine in this regard. So my dear friends, hypertension is considered in our Indian context. The prevalence of this disorder is very much high in our country in both middle-aged and older individuals. Amongst all socioeconomic groups, the prevalence among the younger individuals is underreported. Actually, it is higher than previously estimated. This is especially concerning since this disease can significantly influence patient's quality of life. This disease is a major risk factor for cardiovascular disorders, metabolic syndrome, diabetes, CKD, all of which are also highly prevalent in our society. Patients and clinicians across the country, they should benefit from an agent that provides antihypertensive effect in individuals both with and without additional comorbidities and protect against the development of cardiovascular, metabolic and renal disorders. So when you see the advantages of azelnidipine in Indian context, clinical data available clearly suggests that azelnidipine is suited to fulfill this role. Like many other countries around the world, friends, India is experiencing a population aging process with the number of older individuals expected to almost double by 2050. It is really a problematic thing. This will contribute to an increase in definitely the number of burden of non-communicable diseases such as hypertension and its hypertension-related comorbidities, cardiovascular, metabolic and kidney disease. So this azelnidipine has a variety of beneficial effects in addition to BP lowering effect. In the currently used CCBs for many clinicians in India, azelnidipine appears to be an appropriate, effective and well-tolerated alternative for the holistic management of hypertension. To summarize the things, azelnidipine has been approved for use as an antihypertensive agent across the India. This molecule has several advantages over the current CCBs of choice in India, that is amlodipine and other agents in this class. Benefits beyond hypertension control, allowing holistic management of hypertension and related disorders such as cardiovascular disease and metabolic syndrome. This molecule has benefit on reducing plasma cholesterol, 24 hours BP control, including early morning surge, heart rate, and has negligible incidence of edema. Evidence summarized here provides a good rationale for the adoption of this molecule azelnidipine as a first-line antihypertensive in India. So such a shift toward the use of this molecule in India could substantially help in the country's fight against the hypertension epidemic and improve the quality of life in the patients in the long term. Thank you very much.